Hey folks, Scott Weingart here, and this is an MCrit We. Today I am interviewing Farid Jalali. He is a gastroenterologist, which may not strike you as the most likely person to explore the pathophysiology of COVID-19, but since this pandemic started, he had a burning curiosity to understand what the hell is going on. So he spent 1,000 hours trying to put together everything we were observing from the studies, the autopsy data that's been published with basic physiology, and he came up with a theory. Now, this is just a theory. It is speculative. It is a postulate-based set of ideas. It is not fact. It is not evidence. It is not something that you could look at and say, all right, we got it. This is the best he could come up with, and he spent a lot of time doing it, but it is not proven. And it is hypothesis generating, and it is interesting, and it is accounting for many of the things I have seen that trouble me in terms of COVID-19 being different. In New York, we saw a ton of COVID patients, I think more than anywhere else in a concentrated, discrete area of time. And so we got to notice a lot of clinical things that places that did not see as much COVID-19 may merely be going on their past experience. And most of the explanations for what's going on did not explain what we had observed. And when there is a discrepancy between clinical observation and explanation, that is a problem. This model explains many of the things I have seen. So I hope you will find it interesting, but I cannot state this strongly enough. This is all theoretical. All right, let's get right into it. How the hell did you get into all this?
That's a good question. I I probably should have never gotten into this. Seeing the level of resistance I sometimes read. I was just replying to a couple comments exactly on that. Why is a GI doctor getting into this? Kind of you're meddling in our business and
Wait.
you're
Who is claiming it as their business? I don't know anyone had ownership of this stuff.
yeah, I'll send you the Facebook link.
Okay.
It's a very
Yeah, do
active.
it. I'm curious.
Yeah, it's okay. I mean, I got into it because I wanted to figure out what's going on, and that's the bottom line. I'm trained in internal medicine. I've had plenty of ICU training. It's been a while, sure, but I mean, physiology is not limited to just a few. I mean, we could all
Absolutely.
go back.
Anyone who has a brain and the willingness to look could. I
Right,
mean, look, if
and
you
it's
were talking about the best way to stick a endotracheal tube down someone's throat, I'd look
right,
askance. But if you want to
right,
talk about basic physiology and pathophys of a
exactly,
disease, anyone's open.
exactly. Exactly. And, it's just a model. And, if it turns out to be wrong, well, I tried. If it's right, maybe people can build upon it and find the actual true model. Who knows?
Okay, so I guess this was what, the end of February, beginning of March, that you started saying, I don't quite understand why no one's explaining what's going on with this disease. Is that time course right?
Absolutely. No, absolutely. So, I have plenty of family in Iran, and I used to watch those videos of people falling on the ground suddenly. They're walking to the store, or they're going to to school, and they're not having respiratory distress. They're not having presyncope, and boom, they fall on the ground. And I was talking with my brother, who's a neurologist, and I said, these look like acute kind of events. These look like vascular events. They kind of probably are CVAs, and kind of just went with that for a while and started to kind of put things together that maybe there's a vascular event going on here.
Now,
Sure.
you have a tough task. You have to explain this to me as if, let's say, I'm a fourth year medical student. I
Of
think
course.
I'm a little bit beyond that, but let's make that the level you gear this towards.
Of course.
So let's see if you can really do it. So start us wherever you like and walk us through. And now in the show notes, we're going to have some beautiful images you've made and some additional supplementary text. But try to walk us through your vision of what the hell's going on.
So the entire initial injury to me is one that basically this virus attaches to ACE2 receptors in the epithelium of the lung and the alveoli, and causes whatever injury it causes there. I'm not disputing that there is some sort of an alveolar injury, but then it progresses to reach the capillaries of the lung and attach via the same receptor to the endothelial cells. And it causes an ACE2 downregulation, similar to what SARS does, and similar to even another coronavirus that I think I read about, NL63. The difference between SARS and NL63 in, let's say, that paper was that NL63 did not cause so much downregulation, but SARS did, and was much more pathogenic. And SARS-CoV-2 probably attaches similarly, maybe even with higher affinity, and causes downregulation. And that causes an imbalance in basically ACE versus ACE2 activity, as shown here. And it causes an excess angiotensin II level. I believe that excess angiotensin II level could be counteracted by ACE inhibitors and ARBs, and I think we're seeing studies where they are being shown to be somewhat protective against severe outcomes. And that excess angiotensin II basically acts in several ways. Number one, it causes an intense vasoconstriction, and on top of it, it's pro-inflammatory and pro-thrombotic. So you basically go through this first phase of injury where there is so much vasoconstriction in the alveolar capillaries. And this vasoconstriction basically, progressively moves forward. It also is associated with severe endothelial dysfunction just because of what ANG2 does, increased vascular permeability. And essentially, some of these, constricted vessels begin to have some, microthrombi. It's not a prerequisite to kind of progress along this disease, but it is an unwanted outcome essentially, and that could be prevented early on with anticoagulation and with endothelial stabilization.
Let me pause you there, Farid, for a sec, and just ask for a couple things, which you're already doing, but I just want to make sure they're out there. If you can, as you're describing this, try to tell us how much of anything you say is we know, it's already known fact, like for instance, the effects of angiotensin II, versus your theory on stuff, and try to just give us an idea as we go through where we actually stand in terms of level of evidence. Because some of the things you're going to tell us are known facts, and some of the things are postulates. Is that correct?
That's absolutely correct. And, I also would accept any help you have, you could offer in the middle of this.
We'll see. I don't know. I mean, maybe afterwards I'll say, but I think I could say quite clearly that the model you have laid out is beyond my reckoning. So it feels good, but I'm not. I am very good at the pre-oxygenation physiology. That's where my interests lie, just from a pure utilitarian standpoint. But this stuff's beyond me. And then the second thing I was going to ask is, so really break down what these hormones and stuff are doing, because again, I'm just a fourth year med student, and so while I have vocabulary familiarity, it's only pretend for me to be able to take my exam. But the actual use. So we got to the point where there's going to be increased level of angiotensin II, which is a incredibly potent vasoconstrictor, and therefore we're going to have localized vasoconstriction of you said the capillaries, and I imagine the arterioles as well, or is that intro?
I mean, it's the capillary bed. Essentially, I can't say for a fact whether it's arterial or venous, or is it just the capillaries themselves. But my inclination is to say that the alveolar capillaries are the closest thing to the epithelial cells that first get infected, and those are probably the ones that are most affected by this. The level of evidence in terms of angiotensin II causing endothelial endotype of ARDS, I think that's something Carolyn Calfee has, kind of spent a lot of time delineating. I have to go back and read specific details of her studies to see how she's measured angiotensin might be elevated in the lungs in ARDS, that's endothelial endotype. But in SARS, it's been shown that there is an excess amount of angiotensin II. Again, I have to go back and figure out whether it was actually, staining the lung capillaries or what it was. But this is not something entirely new. And they have done studies that looked at, differential downregulation between another coronavirus versus SARS. And like I said, I can send you that study, but one attaches to it but doesn't really downregulate it and doesn't cause as much of a lung injury at all, whereas SARS obviously does, and it does cause lung injury. So there seems to be a correlation with how much downregulation you have of ACE2 and the severity of the disease.
And
now, you know,
and I had cut you off right at the point where you started discussing microvascular clotting and the occlusion thereof. Is that being caused directly by the excess angiotensin II, or is there some other reason that they're causing these microvascular clots?
I think it's being caused by angiotensin II. I don't have evidence for it, but I think there's been many studies that shown that, let's say given a recombinant angiotensin 1/7 reduces lung injury in ARDS. So we do have some data that opposing the angiotensin II by giving recombinant angiotensin 1/7 improves lung injury, reduces lung injury in many models, including animal models, in vivo models. So I believe it's the imbalance between angiotensin 1/7, which is deficient once this virus basically attaches, and the excess angiotensin II. Early on in March, when people were talking about ACE inhibitor and ARBs, and I kind of made that PDF with what I thought was going on. My only conclusion at that time was when you stop ARBs and ACE inhibitors is when the disease gets severely bad and out of control. And if this theory holds true, that would make complete sense. Continuation of them would be protective. When you stop, especially something like angiotensin receptor blocker, you already have a buildup of angiotensin II in the body, and when you stop it, not only the virus causes more angiotensin II, but stopping the ARB causes even a larger spike in angiotensin II, and disease probably gets out of control. So I think there's a direct injury from this molecule essentially, and it kind of takes over the disease at that point. And kind of moving along here, the angiotensin II excess, it's been shown to cause vasoconstriction. It's been shown to cause endothelial dysfunction. It has been shown to cause, increased vascular permeability, basically cause a prothrombotic, pro-inflammatory, environment in that endothelium. And microthrombi would be one unwanted consequence of this. It's not a prerequisite for this disease to get to where it needs to get. The vasoconstriction really is what's driving it, but it is an unwanted, consequence that we can prevent with anticoagulation. How much of it and in which set of patients we should do it is a big question, but certainly severe patients, we've seen criteria come out of China and elsewhere with D-dimer levels and whatnot. Those patients probably deserve some good degree of anticoagulation to prevent this.
Okay. So where were we? We now have severe capillary vasoconstriction. We have the possibility of microvascular clotting. What does this do?
So essentially, you start occluding the capillary beds in the lungs. And whether it's from thrombi or whether it's from basically a prolonged, intense, vasoconstriction, you start forming, kind of a blockage at the capillary beds. And it seems to affect the dorsal lung for whatever reason, and the peripheral lung more than the rest of the body, based on radiographic, series that we have in COVID-19. And, this model kind of gets a little bit crude from this point on. We can move to the PowerPoint, but essentially, the consequence of this would be dead space ventilation. It would
why don't we go to the PowerPoint? Because I thought those progressions were really cool. So let's go with that.
Of course.
Perfect.
Okay. So this is the normal lung circulation. And again, I don't have evidence for this kind of bronchopulmonary anastomosis being a major player in COVID-19, but we do have evidence that it exists. People with, basically large pulmonary emboli, don't really end up having, significant lung ischemia, because there is basically a mechanism by which the lungs get systemic kind of oxygenated blood to them, despite pulmonary circulation, being clotted off by a pulmonary embolus.
Yeah, well, let me pause you and just say to the people out there. So your bronchial vessels, if you don't remember, are the actual blood supply to the parenchyma of your lungs. Partially that's from the standard circulation, the pulmonary artery circulation as well, but some of it comes from your bronchial artery. And this is a consistent shunt built into the system. This is the problem we deal with ECMO patients. And so, but normally it's a very small percentage of your actual circulation. The vast share is through your pulmonary artery to the pulmonary vein, but some of it is going through bronchial arteries, supplying tissue, and then going to the bronchial veins. Okay, continue.
Absolutely. So this is basically a diagram that's, this has been published in every lung physiology, textbook. This is nothing new. And I'm just trying to kind of show here where pulmonary artery is, where bronchial artery is. And there is an anastomosis between pulmonary and bronchial circulation that comes to play in, let's say, pulmonary embolism. So going to the next slide, when you have a pulmonary embolism, you basically have a blockage in pulmonary arterial flow in the precapillary segment. Typically it's not the capillaries that are clotting off with super tiny microthrombi. It's usually a larger clot. And what happens is oxygenated blood flows through the bronchial artery coming from the left side of the heart and crosses through the bronchopulmonary anastomosis per these arrows and perfuses, the lung parenchyma to prevent ischemia when you have such a drastic cut to blood supply from pulmonary circulation. So this has been shown. I don't think there's anything new about this. How often and how common and what the distribution of these bronchopulmonary anastomosis are, I really can't find that information. I have looked at autopsy studies and bronchial, selective angiography of bronchial circulation when they basically clot, stop the flow from pulmonary circulation to kind of delineate, how many patients have these. And it seems like most people have these bronchopulmonary anastomosis. It would make sense because most people don't develop lung ischemia after pulmonary embolism. But I simply don't know where these are and how common these are. So moving on to the next slide, basically getting into, COVID injury. If we are to assume that, excess angiotensin II does occur in the pulmonary endothelium, then you would expect to have, basically a near occlusive kind of a flow in the alveolar capillaries, mediated by angiotensin II. They would cause intense vasoconstriction and in some instances microthrombi. But again, they're not a prerequisite for how this disease progresses.
And just to clarify, the vasoconstriction is definitely a necessity to the model you're laying out, but you're saying
yes,
the thrombi
absolutely.
may or may not be there.
Absolutely, 100%. It's a necessity, and I had a chat with somebody in Belgium who had done pretty decent, neat, functional imaging of the lungs, and I can share those slides with you later on. But he's gone through numerous number of CTs, and he has data to prove that there's intense vasoconstriction happening in basically very small arterioles and capillaries in COVID-19, and it's a complete departure, very different from what happens in ARDS. I'll send those slides to you later on. But
very cool.
There's definitely evidence there, imaging-wise.
And so far, what we've created by this model is there's been increase in the patient's dead space, and therefore they're going to desaturate on room air, and there's seemingly going to be a buildup of localized pressure in those pulmonary arterioles at this stage.
Right. So step 2, just moving along, when you have locally impaired pulmonary circulation, these bronchopulmonary anastomosis begin to shunt some oxygenated blood from bronchial to pulmonary circulation per these yellow arrows down here. And, that's what we expect to happen, to, deliver some oxygenated blood to this parenchyma to prevent ischemia. Moving along, as the lung endothelial injury worsens, as you have more vasoconstriction, possibly some microthrombi, but as this, vaso-occlusive disease in the capillary bed progresses, you begin to have dead space ventilation, just like you said, which is basically minimal perfusion to an area of the lung that has normal ventilation. That's a high VQ mismatch. V is pretty high, V is not pretty high, V is actually normal. Q, the perfusion is pretty low, the ratio becomes super high. And high VQ mismatch is generally associated with, derangements in arterial, basically CO2. Yes, it would affect oxygenation as well, but for the most part, it's the effect of it is measured by mainly the derangements of CO2. If you look at all these recent Gattinoni studies and all these other people, that's kind of how they try to subdivide what parameter they're looking at for high versus low VQ mismatch. So in this slide, we look at a little bit of what's going on in the alveoli. And I think this is a very important slide. It's a concept that every time I talk to a pulmonologist, most of them are like, what are you talking about? But if you look at, studies on alveolar hypocapnia, this is from a study from 1964, and I know that sounds funny, but there has been more recent studies that have shown the same thing. In these alveoli that have a high VQ mismatch, you basically cannot, exchange CO2 very easily, very well. So the alveolar space has hypocapnia. The vascular space obviously has lots of CO2 to get rid of, but it can't. So alveolar hypocapnia in the dorsal lungs, which we know gets most affected in COVID-19, it happens to be dorsal lung for whatever reason. This leads to alveolar duct constriction. In other words, the body is trying to tell you, please do not open and close these alveoli so much because I have some dead space, I have some bad perfusion in here. And this redistributes the ventilation to areas with less VQ mismatch. So that would be the ventral lung, essentially, telling, the inspired, the inspiratory volume that you're taking in is going to ventral lungs. So then, therefore, you have more of a CO2 exchange in the ventral lung, more ventilation there, and the ventral alveoli will have hypercapnia because they're trying to get rid of all the CO2 that's built up. And hypercapnia there leads to alveolar duct dilation in the ventral lungs. And overall, you have the dorsal lung with alveolar duct that are constricted, increasing resistance, but then the ventral lung will have dilated alveolar ducts. And when you add them overall, you have a preserved, overall resistance to airflow, preserved overall compliance in this stage of the disease.
Now, Farid, you said there was disagreement amongst the pulmonologists. Are they disagreeing with this as a basic physiologic protective mechanism or whether it exists in COVID specifically?
I've had people say, what are you talking about? This doesn't even exist. I've had many people say this, and I certainly think it exists. I mean, there's even histologic evidence in this paper, and I can send you the link. There's even more recent, studies that this exists. It's just not talked about as much. And I think in dead space ventilation, this is a protective physiologic response. And this is really the crux of what I'm trying to say in COVID-19 is you do not want these alveoli with poor perfusion, with dead space ventilation. You don't want them to be basically distended. That's why low tidal volume probably works in ARDS. It probably works in COVID-19 is because we're basically, by distending these, and I'll go to that in the next slide, by distending these, you squeeze whatever little flow is left in the alveolar capillaries. And that's also something that's been established. It's nothing new here. It's all physiology, essentially.
And what makes this different so far from what I'm hearing from our standard ARDS is that we have specifically this profound capillary vasoconstriction and the possibility of clots, making for a different physiologic milieu than we're normally used to. That
Absolutely.
normally it's the alveolar space itself that's being consolidated, and all of our issues flow from a compliance change due to an alveolar issue rather than a microvascular issue. Is that correct?
Absolutely. And, in typical ARDS, first of all, it's so heterogeneous, but, probably more commonly, you don't have so much intense vasoconstriction in the alveoli. You might have even vasodilation in the alveolar capillaries or maybe a neutral response. But this is just a unique disease with so much vasoconstriction, if we are to believe what's happening with angiotensin II and all that stuff.
Okay.
So, moving on to the next slide, you have progressive occlusion of the alveolar capillary bed. And again, I'm kind of just, putting some yellow mark in the alveoli. That could mean just vasoconstriction. That doesn't have to be significant, overwhelming microthrombi. But essentially, you have a progressive occlusion of this bed, leads to backflow of pulmonary arteriolar blood that builds up, and it will start to find a way out. And bronchopulmonary anastomosis, again, if we are to believe that it exists diffusely, is defunctionalized probably for most patients at normal times, but that would be one way out. It would be the bronchopulmonary anastomosis along those yellow arrows that I've put on there. And, and this is where kind of, you all's experience in the front lines probably comes into play. Is from what I've read and from what I've heard, there's not a huge overwhelming evidence that there's pulmonary arterial hypertension developing in these patients. And the only way I can put it together if this is happening is basically this flow diversion through this intrapulmonary shunt.
Now, at this stage, for this model to make a lot of sense to me, there need to be a difference in the effects of angiotensin II on the bronchial circulation versus the pulmonary artery circulation. Is that the case? Why are we not seeing the intense vasoconstriction on the bronchial side as well, and therefore it would be just as occluded?
That's an excellent question. And do I have a perfect answer for it? No. My thought, again, is this virus enters through alveoli, through the epithelial cells, and the alveolar capillaries are just so nearby that most likely they're going to be the ones, number one, from proximity standpoint, most likely they're going to be the ones that have the probably just being affected the most. And secondarily, they have the smallest diameter to begin with. So, some vasoconstriction in alveolar capillaries would mean, basically occlusion of flow, whereas, other larger diameter vessels, sure, they may be vasoconstricted, probably not as much because they're not as close to epithelial cells, and probably not as clinically significant as constricting a bunch of really tiny capillaries.
All right. So one postulate that would be wonderful for this model to be proven is if there was actually postmortem histologic evidence that there is a variance in effect of the pulmonary artery circulation in terms of, I guess we wouldn't be able to see vasoconstriction at that point, but that there would be some difference between the bronchial circulation and the pulmonary artery circulation that would account for why the flow is not as impeded on the bronchial side.
Absolutely. And if you go back to the autopsy reports from New Orleans, and I believe even another one, they do talk about, I even think they wrote something along the lines of unusually distended vessels that don't have microthrombi in them. And that always puzzled me. And I was like, okay, what are these unusually distended vessels? And could it be this? Could it be something along the lines of this happening? I'm not sure, but there's some evidence that something's going on with microthrombotic, maybe smaller, capillaries that are injured, and then you have these, on the other hand, these distended vessels. Who knows?
Okay, so now we have pressure building up in the PA, and now our next slide is going to show us where the shunt comes in.
Right. So essentially, you have progressive, back pressure build up against this occluded capillary bed, and this leads to progressive distension of the precapillary arterioles in the, pulmonary arterioles, and, in the direction of these yellow arrows. And if you carefully look at all the CT angios, and this has been mentioned over and over and over again, that one unique characteristic about COVID-19 lung injury is these distended vessels. They seem to light up on the arterial phase. they're a short segment. They're not kind of extending in a tapered fashion all the way to the pulmonary, artery. It's a short segment that keeps distending more and more and more, and then it collapses toward the end of the lung injury. And I believe that precapillary pulmonary arteriole that I'm showing here is most likely where the distension occurs. And the reason it's short segment and it's kind of just abruptly stops being distended is probably it finds a drainage out through this bronchopulmonary anastomosis, which we know it is in the precapillary kind of pulmonary arterial kind of space. It's in that range where it occurs. It's not really at the capillary level so much. So this pressure buildup will basically cause, this reversal of flow, if you will, across this bronchopulmonary anastomosis, go to bronchial circulation, and drain from bronchopulmonary vein (BPV) over there into essentially pulmonary vein and drain into the left atrium. And this is basically what I think is happening with what Gattinoni and everybody else is describing as hyperperfusion to gasless tissue. If you look here, alveoli are up here, you're hyperperfusing through this channel to a segment that's far from alveoli. I know this is not something that necessarily pulmonologists agree with much, with me saying there's diffusion impairment here. We always think about that as, fibrotic and whatnot, but to me, you have a huge distance to get from, the blood that's circulating, let's say in this capillary bed in the bronchial circulation. You have a huge distance from here to the alveoli, and there's some inherent diffusion abnormality probably.
Yeah, I don't even know if there would be diffusion full stop. The bronchial circulation was never meant for gas exchange. It was meant for...
Right.
And so if this is the case, we already had dead space from the earlier slides, and now this is actually physiologic shunt, and this would be the oxygen non-responsive portion of the disease, and this would be persistent hypoxemia regardless of supplementation of FiO2.
Absolutely, 100%. So, essentially this would be the low VQ mismatch. If you increase partial pressure of delivered oxygen, essentially, you will get some response potentially you get some response in terms of your hypoxia. But absolutely, you're right. This would be the phase where hypoxia is basically deeply set in, and no matter what you do, it's very hard to kind of reverse it at this point. So going into the next slide, and again, these slides basically, build on what the model was here with dead space ventilation followed by intrapulmonary shunt. So, there is a possibility I may be wrong, but if this model is right, then what you would expect with increased systemic vascular resistance, such as Valsalva or systemic vasoconstriction at this late stage of the disease, you would have increased, pulmonary arterial flow, and this would essentially cause more of a disturbed, turbulent kind of a flow in this dilated segment, and eventually all of this should back up and increase the pulmonary shunt flow, and this would essentially cause worsening of hypoxia if we are to believe this model.
Yeah, well, let's put a pin in well, not a pin in it, but let's briefly discuss here that if this really is the case, what we've seen quite commonly, because we run these patients so dry, is that once we put them on mechanical ventilation, they inevitably have a drop in their blood pressure, and a lot of times they may get put on systemic vasoconstrictors. And if this is true, it would be one explanation for why we see a marked decline once patients are intubated. So it might actually be a secondary thing we do once a patient gets intubated that is radically exacerbating their lung situation.
Right. I mean, I think, euvolemia is probably what should be pursued. This is probably a little different than regular typical ARDS with, vasodilation and all the vascular permeability from that. This is, probably a little bit different as we're trying to say. And I agree with you. Again, that's all I've heard from people on the front lines. Obviously, again, I'm a GI doctor, but that's exactly what I've heard from other people, what you mentioned.
All right.
In this phase, I think pulmonary vasodilators would not probably be the right thing to do. It would probably do the same thing by increasing flow through the pulmonary circulation and again, worsening this shunt. At a prior stage, before this shunt develops, when you have all this vasoconstriction, pulmonary vasodilators would probably be the right thing to do to actually prevent all of this from happening. So at different stages of disease, the same thing may not.
It's interesting because in the portion of the model lacking the microthrombi, then the potential of a inhaled pulmonary vasodilator to work is there. Maybe it could overcome the angiotensin II. If you're dealing with microvascular thrombi, then ostensibly those vascular mediators would never get where you wanted. They would only go to places that aren't actually experiencing the blockage from the microvascular thrombi and therefore would not be beneficial. So there might be a heterogeneous, oh my God, it's too early in the morning. You understand what I'm saying?
Absolutely. And again, this is just a model. I'm not sure about it, but if we are to believe this is happening, yes, early on it would help. Later on, it would probably be harmful even to mainly hypoxia. It probably wouldn't do much to death space ventilation, but it would be worse to the shunting and the hypoxia.
All right.
Prone position improves dorsal predominant intrapulmonary shunt physiology. And again, I understand this is going to cause some headaches and there's going to be major disbelievers in this, but I believe prone position in COVID-19, number one, it seems to work so reliably where even in ARDS, only in the severe subset and only in a subset of patients, we find that it works reliably. But in this, even awake proning, with people that are hypoxic seems to work. And I believe it's because it redistributes flow. These intrapulmonary shunts, most of the damage is happening in the dorsal lung. Why? Again, I have no idea, but it happens in dorsal lung based on CT evidence. The dorsal lung would basically be holding these intrapulmonary shunts, these dilated areas with turbulent flow, and it's just stagnant, and it's basically a shunt. And the dorsal lung being supine, you would have pooling in these, dilated spaces, just like you have pooling in lower extremities when you're standing upright. When you prone them, you essentially remove the pulling, of the gravity, pulling blood into these dilated spaces. And your dorsal lung having these things goes essentially up, kind of like your feet going up, when you put them up. And you have basically less capacity and less blood volume in these shunts. And essentially, it would decrease the intrapulmonary shunt portion that's happening and drastically see an improvement in hypoxia.
All right. So this would be a explanation potentially for why we see a very different way that our proning is working in this disease. And, that was always a big question for us. And because standard proning, again, revolves around changing the blood flow to non-consolidated alveoli, but this again becomes proning working on a vascular explanation rather than an alveolar explanation. So it works, but it's different as to the reasons why.
Right. In typical ARDS, again, the idea is the teaching is that you have dorsal lung with predominantly constant best perfusion. They've done, Gattinoni and all sorts of other people have done perfusion studies in ARDS. And when you prone or supine them, perfusion is only mildly changes with prone and supine, according to what they say. But these alveoli in typical ARDS, when they're supine, you have the effect of gravity and the pressure of the heart and all these other things causing basically atelectasis and difficulty opening these alveoli with supposedly best perfusion, they say. So when you prone them, you remove the gravity, you remove the weight of the heart, and you allow these alveoli to better open up, more easily open up. Again, they have the best perfusion to begin with, and therefore you have a better matching of ventilation and perfusion. And that's how it helps in typical ARDS. In this disease, I just don't think you have too much of an alveolar injury with, trying to get them open up or whatnot. And it's probably a flow redistribution more than alveolar recruitment. I think even Gattinoni in some of his recent articles has started coining the term vascular derecruitment. Even before COVID-19, and I think that's the term that should be used here, is you're derecruiting these vasculature that are not working properly, essentially, with intrapulmonary shunts.
Got it.
So going on to the next slide, and this is going to be much more controversial even than the one before. Again, I don't have any evidence for this. This is just physiology. I don't mean to cause any sort of anger or disbelief in pulmonologists. Please, mechanical ventilation is needed when it's needed. So I'm not suggesting that's a bad thing. What I'm trying to suggest here is to intubate and mechanically ventilate, let's say with a PF ratio of 300 or 400, as as we would even do in typical ARDS, to kind of prevent alveolar injury. We intubate them, put them on low tidal volume and whatnot to prevent further alveolar injury. I think that whole idea may not apply so much in COVID-19, and this is my attempt to explain that.
Okay, walk us through.
So as we've kind of established so far, again, it's a model, it's not established, but you have dead space ventilation and you have an intrapulmonary shunt. Higher lung volumes, and this has been established, this is physiologic data, it's nothing new. Higher lung volumes cause increased resistance in alveolar capillaries. And at the same time, they would cause decreased resistance in extraalveolar vessels. There's nothing new there. So if we are to believe this model is true, increased resistance in alveolar capillaries means you diminish alveolar capillary flow. Whatever little is left, whether it's vasoconstriction or microthrombi or both, you diminish that even more. You worsen the high VQ mismatch, which is number one in that slide.
Yep.
At the same time, you decrease resistance in extraalveolar vessels, and those would be basically non-alveolar capillary vessels. There would be the bronchial circulation and other things. And by decreasing resistance in those, you essentially just basically allow more intrapulmonary shunting to happen. You're squeezing number one, you're opening number two, and it's not too far-fetched to imagine that's going to increase the flow in the shunt. And that worsens the low VQ mismatch in these people. So you simultaneously cause two injuries, both in high and low VQ mismatch. So I believe this is the reason low tidal volume would be advisable, obviously, in COVID-19. This may have something to do with even typical ARDS. Even in H1N1, we know ACE2 downregulation happens, and this may be part of the pathophysiology even in H1N1. I don't really know. But essentially, you worsen the, like I said, high and low VQ mismatch. And number three in this slide, I don't have any evidence for this, but I would imagine that if there was even a little flow left in the bronchial kind of capillaries, kind of anastomosing with the alveolar capillaries, which we know exists, that also would be shut closed essentially. So that little trickle of blood flow preventing some ischemia around the alveoli coming from bronchial circulation in number three, that would kind of go away probably. And we do know number four happens. You'll have progressive venous congestion in the bronchopulmonary vein, draining into pulmonary vein. That's been shown in PEs and whatnot. And the combination of all these four essentially leads to an accelerated lung injury, possibly. Not guaranteed, not every time, but possibly. And this could set off basically lung parenchymal ischemia. Do I have any evidence for that? Absolutely not. From my standpoint, what I don't understand on these autopsies is when they talk about these areas of hemorrhagic parenchyma interspersed with gray tan areas of the lung. And I don't really know what those gray tan areas are. In GI, we kind of think gray tan areas means ischemic, but again, I have zero evidence to suggest this is happening. But if it is happening, then that would cause basically a cytokine storm, possibly after initiating mechanical ventilation or positive pressure ventilation of any significant amount. And that could be what we see with people potentially, having a downturn after intubation, with hypercapnia developing and acidemia developing. Could it be partially this? I have no idea.
Yeah, that's all fantastic. Let me pause you to ask a question that's been lingering in my head, and this might be a good time to ask it, which is, up until this point, let's say before we get to the mechanical ventilation stage, if this is primarily a vascular situation, what is causing the horrible radiographic findings we're seeing? What is causing these ground glass diffuse infiltrates on the lung? What are we actually seeing? Have you looked into that?
So, that's a good question. And if you look at, I'll send you this CT study where they actually chronicled CT changes in 2 patients, and they, there's the initial ground glass opacities, and I think those reflect basically these alveolar capillary vasoconstriction and the endothelial damage and vascular permeability that happens from angiotensin II excess. And they're usually, pretty small, amounts of ground glass opacities. As the disease progresses, you see progressive vascular distension. Again, a limited amount of, a vessel is getting distended, and it's getting distended more and more and more, and it collapses. And that's when the GGOs, these ground glass opacities, exponentially increase. Is as the vessel is getting more and more distended, and it collapses, then it basically, you have a large increase in these GGOs. And the next few slides go over that. But basically, as this backflow increases, you'll have more interstitial edema, more hydrostatic pressure, more interstitial edema. Eventually, you'll have more even alveolar edema. You'll have breakdown of, epithelial, endothelial barrier, and you get an exponential increase in these basically infiltrates. That's what I think is going on. I'm not sure, but that's
so it's definitely possible then, from what you're saying, that these horrible lung findings could be a vascular phenomenon, and that would explain the B lines we see on ultrasound, which is always an interstitial sign, not an alveolar sign. And so even though we're seeing these diffuse signs of lung disease, it might be lung vasculature and the areas surrounding it rather than lung alveolar disease.
Absolutely. I mean, I think even early on, when we go back to that slide with alveolar hypocapnic, bronchoconstriction, seeing on CT non-aerated areas that correspond possibly with these microvascular kind of occlusive disease that we see in COVID-19. Those non-aerated areas essentially could be alveolar hypocapnic bronchoconstriction. I mean, I'll send you the study on that, and histologically, you can even see these alveoli, the alveolar duct collapses so much that all these alveoli are basically much tighter packed, and essentially it's non-aerated. So, you don't have to have alveolar edema from a typical ARDS just to have a non-aerated piece of the lung. It could be a physiologic response, as I explained in this previous slide, that basically the lung is trying to tell you, please do not distend these alveoli. I'm having some trouble with my capillaries. Don't mess with it. Just let it be, please.
All right, fair enough.
So moving on to the next slide, even in absence of mechanical ventilation, in absence of proper early aggressive endothelial stabilization, and I know this gets a little tricky trying to prove this, but basically the typical stuff we do to stabilize endothelium, I think ACE inhibitors and ARBs would actually be very protective. Other things that we do, with statins and N-acetylcysteine and all sorts of other things that I've sent in the, one of those slides that I sent you before. In absence of stabilizing the endothelium early on, in absence of proper anticoagulation to prevent these, unwanted microthrombi to happen, and in absence of a flow redistribution with prone positioning, this lung injury could also progress even without mechanical ventilation, unfortunately. And essentially the same sort of damage happens. I haven't really changed much in this slide. You have worsening high VQ mismatch, you have worsening low VQ mismatch, you have the shunts that are getting congested, and you basically get progressive lung injury. You get some parenchymal ischemia, possibly. the endothelial epithelial barrier breaks down, and eventually you'll get diffuse alveolar damage. You don't have to have mechanical ventilation. I'm not saying that's what's causing diffuse alveolar damage, but it could possibly accelerate it. But nevertheless, you'll have diffuse alveolar damage toward the end stages of the disease. And moving on to the next slide, and basically, as kind of answering your question before, we talked about this. The late lung injury is characterized by poor lung compliance because now you have progressive interstitial edema, you have hydrostatic pressure buildup, you have progressive alveolar damage, diffuse alveolar damage, you'll have alveolar edema, and I personally think you're going to have progressive some sort of a bronchial distortion. I mean, all this extra flow going through bronchial circulation, it must do something to the bronchioles. Again, I have no evidence for this. I think CTs show that not too uncommonly you have bronchial distortion toward the end stages of this disease, but I can only imagine it should do something to the bronchioles.
Yeah, and these patients, even after we get them extubated, still look horrible. This is something, unfortunately, persistent has occurred in their lungs that is not resolving, right, at least right away. So at this stage, things are not going to look great even after we get the tube out.
Right. And, toward the this is the very last slide, but I think there is a cycle of ischemia reperfusion happening in these patients, whether it's from innate fibrinolysis, D-dimer is a sign of that's happening pretty aggressively, or whether we give them thrombolytics or give them late anticoagulation. You have a very severely injured endothelium with high degree of vascular permeability because of prolonged deep vasoconstriction, thrombi, and injury. And once you restore flow, well, I mean, it's going to cause severe interstitial edema, alveolar edema, and essentially have a pretty significant reperfusion injury in these patients. So it's not far-fetched to think that TPA should work, but the patient may not survive it because of what's happening with these, with this reperfusion injury.
Okay. Where do we stand now? Okay, let's do these take-home points. That's fantastic.
Yes. So again, these are just my ideas. It's not supposed to be something that, people should really listen to or even practice based off. But again, my thought is early endothelial stabilization before even hypoxia sets in is key to prevent this, COVID-induced excess angiotensin II mediated intense alveolar capillary vasoconstriction, as well as all the, pro-inflammatory, pro-thrombotic events that happen from this angiotensin II excess. And I believe all of this forms the very basis of the lung injury in COVID-19. I think endothelial stabilization, and I have some, interventions in the other slide, and I can send you, but this should be the very early thing we do, even before hypoxia sets in. I've talked to a couple people that have had studies done, with polyphenols and curcumin and other things in other endothelial injurious, lung processes, not COVID, and they have good, very solid data to back it up. And they think these are just some supplements that people can take to perhaps even reduce the severity of the injury in those that are going to end up with severe disease. Once you have hypoxia set in, supportive care, again, I think should include early and aggressive endothelial stabilization, and then properly dose anticoagulation to prevent these microthrombi. Supplemental oxygen, I think maybe avoiding positive pressure ventilation based on what I described should probably be better. Early intubation, which we don't hopefully do anymore, probably is not going to, be helpful. It might even potentially accelerate the lung injury. I may be completely wrong on that, but an awake prone position to redistribute flow, as I explained, to redistribute perfusion away from these beginning to form kind of dorsal predominant shunts. Those should be, as all of you are doing, should be, what's happening. And again, alveolar capillary microthrombi are not a prerequisite, but they're clearly a step in the wrong direction if allowed to be formed.
Now, Farid, in this model, I didn't see anywhere where the 5G cellular towers are actually influencing this disease, and nor did I see the injected bleach being a potential benefit. Yes. So I really think this model is lacking.
It's lacking. Yes, I agree. It's lacking. And again, I posted this on social media, mainly in physician forums on Facebook, and I haven't checked in half hour to see what the response is. But there is a large degree of resistance to this being just unfounded. And I've asked people, please tell me where this is unfounded. Yes, the angiotensin II, sure, we don't have clear data on that, but honestly, the rest of everything else I'm saying here is just physiology. You can open up any lung physiology textbook and it would show this. The location of the shunt, sure, that could be made up, but again, we do have evidence that hyperperfusion occurs, that these vascular distensions occur. So hyperperfusion to gasless tissue. So take you should take from this whatever you can and move on if it's not something that you agree with. But it is just a model.
So that was my next question is, are there competing theories that contradict what you have said, or is it just that people are saying,
No.
No, you have no proof for this? But
Yes.
So there's no major competing theories that are being put out that would go
No.
against anything you've said so far.
Again, Scott, I mean, I've put in, my wife would not be happy hearing this, and she knows it, but I've put in probably a couple 1,000 hours on this in the last, 6-7 weeks, trying to think through this and read and read and read. And I believe this incorporates everything we're seeing clinically, everything that's been reported by people that are measuring things objectively. And as you said, there's no competing theory as far as I have found. There's nobody that's even like arguing that you are wrong here. They're saying there's no evidence, and I concede there's no evidence. But let's work on building based on whatever model that's best fits, and let's ask the questions based on the model. I mean, if we put these people on trials without having a proper model to kind of ask the proper questions.
Again, thank you, my friend. And stay in touch. If you think of any new stuff or ideas, by all means, send it
Absolutely.
our way.
Thank you. Take care.
All right. Have a wonderful day, my friend.
You too. Thank you. Bye.